All right. Good afternoon, everyone, and welcome to Grand Rounds. This afternoon we have the Dermatology Unit and Associate Professor Andrew Miller presenting on autoimmunity and when to consider malignancy. I think most of us know Andrew very well as a very busy dermatologist who's really been the stalwart of our dermatology service at the Canberra Hospital for years, as well as working in private practice and providing some outreach clinics regionally. But at the Canberra Hospital, there's a General Dermatology Clinic still, as well as rapid access. And I wanted to mention also the Dermato-Oncology Clinic, which is very much appreciated by the Canberra Regional Cancer Centre. So I'll hand over to Andrew.
Thanks very much. Yeah, thanks, Nicole. We're good? Okay, good to go. Excellent. All righty, so I was wondering how to approach this subject. We've had a couple of cases which we'll present this morning that caused me to reflect on what is the nature of this association between malignancy and autoimmunity. And I guess many of us come to it with this sort of naive view that there's this immunologic autoreactivity, and at the other end of the spectrum, there's immunologic failure, which represents cancer. But in fact, the relationship between immunity and cancer is far, far more complex than that. And we'll go into this a little bit with the talk today. So I'd like to start off dealing with the things that we know, the known knowns about cancer and autoimmunity. So there is good evidence sitting behind conditions like Sjogren's syndrome and rheumatoid arthritis showing associations between these and malignancy. And also we know that if you flip the coin, there are a number of autoimmune conditions which we know have a definite association with malignancy, such as dermatomyositis and paraneoplastic pemphigus. And this brings me to the first case that I'd like to highlight at this point. So she's an 87-year-old lady who presented with a 7-month history of painful ulcers on her lips and in her mouth. She had discharge from her eyes, and I think you can see that there's evidence of erosion there. She also had perianal erosions and blisters on her trunk. So examination I've already essentially summarised there, but these are really consistent with a clinical diagnosis of pemphigus vulgaris. So presented with this, proceed along that line and investigated by biopsying to confirm the diagnosis. An oral mucosal biopsy was performed, which showed extensive acantholysis with erosions. Direct immunofluorescence showed intercellular IgG and C3. And indirect immunofluorescence was positive for intercellular cement substance antibodies. So that is all very consistent with a clinical diagnosis of pemphigus vulgaris. The clinical scenario, however, took that a little bit further. Pemphigus vulgaris is by and large a disease of middle life, so 4th and 5th decades. If we see someone significantly younger than that, we consider some primary immunological disturbance. And if we see someone significantly older than that, we consider the possibility of it being a paraneoplastic phenomenon. So, in fact, paraneoplastic pemphigus is an immunologic distinct variant of pemphigus vulgaris. It has different antibodies associated with it. Rather than the desmoglein antibodies that you see with pemphigus, you see anti-envaplakin antibodies, and the specificity is really extremely high for that diagnosis with a reasonable sensitivity as well. So it's actually quite a distinct disease. And it has an extremely strong association with hematologic malignancy, over 80%. It does have with other cancers as well, but the vast majority of hematologic malignancies, which are the commonest, are non-Hodgkin's lymphoma and CLL. So in this particular instance, we proceeded to investigate this lady, and amongst our primary investigations were hematologic, and we found that she had an IgM paraprotein of some significance with an evidence of an immunoparesis suggesting that this was a significant problem, and she was referred to hematology where the diagnosis of Walton-Strom's macroglobulinemia was confirmed. She was treated with prednisone initially to give her symptomatic control of her blistering disease because oral input had become a problem. And after discussion, particularly in view of her age, it was decided to proceed to management, active management of her Waldenstrom's because of the association with her disease. And she was treated with rituximab, cyclophosphamide, and continued prednisone. And her pemphigus and the macroglobulinemia remitted. Her IgM paraprotein became essentially almost undetectable on an EPG. 3 years later, she presented with recurrent lip erosions. Biopsy confirmed a recurrence of the pemphigus. Rescreening demonstrated a recurrence of her paraprotein to significant levels again. And at this stage, she was recommenced on prednisone. By this stage, she was 90, and the wisdom of proceeding with more active treatment was debated. It was instead decided to try treating her with prednisone as monotherapy and tapering down, and that worked really well. She sadly died this year, which was 3 years after this flare-up from the effects of myelodysplasia. So we've got the known knowns covered off. These are conditions that we're really familiar with, where we automatically start to consider the possibility at some stage of their course of malignancy. I'd like to move to the known unknowns. That's basically where we know that there may be a risk and we need to work out how to plan and screen for them. These occur really in 2 broad contexts. You can have malignancy linked to autoimmunity treatments. I've very uncharitably referred to carcinogens there, but they're particularly the alkylating agents, which we know have this incidence of second malignancy associated with them, but also just the net effect over the years of immunosuppression, bearing in mind that many of these autoimmune diseases occur in older patients who already have a significant risk of malignancy. But not to forget that autoimmunity can be linked to malignancy treatments in their own right. And immune checkpoint inhibitors are the ones that we consider immediately leaping to mind. We did grand rounds on this a couple of years ago, demonstrating the significant association of autoimmune disease of very wide nature with use of immune checkpoint inhibitors, which are increasingly becoming a feature of management of malignancies. But I also put taxanes in there because they have a reasonable incidence of induction of particularly cutaneous lupus associated with their usage. But what I want to move on to is the unknown unknowns. These are the ones where something odd is happening and you're not really entirely sure how to work it out. And the reason this sits behind the presentation today, because I'm aware that there tends to be a tendency to go with broad scattergun assessment when you're not sure what's going on. So let's put a little bit of rationale behind it. And so what we'll do to start off with is I'll ask Dr. Cowan, our registrar, to present the next case. Just the space bar.
Yes, thank you, Prof Miller. So I'm presenting this case of a lady who presented to the emergency department here at Canberra on the afternoon of my birthday with an unbearably painful rash for about 4 months and looking like she did in this photo here. She's a 67-year-old lady with a history of hypertension and bowel cancer in remission, which was initially treated with surgery and chemotherapy back in 2006. She then had a liver metastasis in 2009, just treated with resection, and had follow-up since then with subsequent remission. She developed these painful annular lesions that were evident in the photo about 3 or 4 months prior. She had a biopsy before she came to the emergency department externally, which revealed a lichenoid reaction. This was initially thought to be a lichenoid drug reaction, possibly due to one of her antihypertensives, which was then swapped over. She had this ongoing rash and pain despite that change, and so she ended up presenting to the emergency department with worsening pain. On further review, she'd lost a little bit of weight over several weeks, which was fairly non-specific. She described some anorexia, which was quite vague, and had a few subjective fevers over the last few months. She didn't have any mucosal lesions, no bowel changes, no abdominal pain, and no infective symptoms. We admitted her under dermatology and commenced her on topical steroids, started her on prednisolone due to the severity of her presentation, as well as analgesia, and we performed an autoimmune screen and repeat biopsies. On autoimmune screening, she had a positive ENA, although her ANA and double-stranded DNA were normal and normal complements. Her repeat biopsy showed this ongoing lichenoid inflammation, but a negative immunofluorescence and no evidence of any vasculitis or increased dermal mucin. We treated her as a subacute cutaneous lupus with prednisolone and started her on Plaquenil with ongoing steroid wet dressings. Unfortunately, she was really slow to progress during her admission, and she had this ongoing minor lymphopenia. Because of this lymphopenia and Professor Miller's gestalt, I guess, we ended up screening her for possible underlying malignancies, particularly given her history of bowel cancer. Her tumour markers were slightly abnormal and she had this ongoing lymphopenia. And so we initially started with a chest x-ray, which was normal. We progressed to a CT though, and on a CT chest, she had this evidence of a lung mass, which was PET avid. This was biopsied and it proved to be a pulmonary SCC. She has since had this resected just over the last couple of weeks, and her skin has improved on the treatment that we have started. She was having ongoing Plaquenil and a weaning course of prednisolone at the last time we met her, and just using topical steroids now as required, with no ongoing skin pain.
Thank you, Tim. Does anyone have any questions about the case? Yeah.
Andrew, this is an ongoing issue. Let's say you suspect cancer, focus. And so, apart from sort of legal gestalt, was it a pan scan that you ordered on this person, or was there something why you CT chest?
With the CT chest, there was a little bit of obfuscation in the report. Was essentially the reason why we proceeded on, and the reason for the actual outcome was, to my mind, a little bit of a surprise. I was expecting to find evidence of recurrence of her colon cancer, to be honest, but it was essentially, we started with the chest, and I think it also panned out to the way the department did it, because we were intending to proceed on to others if we didn't find it. But it was on the basis of a somewhat obfuscatory chest X-ray report that we thought we should proceed to doing the CT. Yeah.
So isn't a master it's my understanding.
Yes, indeed. That's a good question. Yeah. And
was that it was detected.
Yes, it was detected. Yeah. The ENA screens came through a little bit later, so we'd actually embarked on our course already as those screens came through. But indeed, yeah, there are certainly, and anti-RMP3 is a good marker for looking for malignancy. No other questions? Okay, we might move on to the next case. Dr. Yeo, present.
So good afternoon, everyone. Today I'll be presenting the third case. So I'd like to present the case of Mr. DB. He's a lovely 50-year-old gentleman who's a retired truck driver who first came to our attention when he presented to Canberra Hospital Emergency Department in September of last year for cutaneous eruption. At that time, phone advice was sought and we advised for some topical therapy and punch biopsy of his back. The salient findings, as you can see, is that there was a tiny focus of subtle basal brachial interface change, and this potentially could portend his future diagnosis. This is on a background of a ute injury the year before, for which he presented to emergency as well. They did a chest x-ray, which excluded any rib fractures, but they did find an ill-defined opacity in the right upper zone. So we reviewed Mr. DB again in our clinic a week afterwards. By this time, his morphology had evolved, so we rebiopsied his left back, and this time it came back as a lichenoid reaction with interstitial mucin, which is quite indicative of subacute cutaneous lupus. Subsequently, an outpatient CT chest was performed, which diagnosed a right upper lobe mass, along with regional lymphadenopathy, He was subsequently seen in a respiratory clinic in November and revealed that he had experienced night sweats since February, as well as a non-specific rash for 6 months prior. This is on a past medical background of asthma and allergic rhinitis and a 16-pack year smoking history. So respiratory team did an endobronchial ultrasound with lung brushings positive for primary lung adenocarcinoma. We saw him again in our clinic a week afterwards and upgraded his topical therapy to a potent topical steroid. Multidisciplinary meeting diagnosed him with a stage 3 unresectable lung cancer and advised for chemotherapy and radiation oncology. At this time, he also had a PET scan which diagnosed local regional metastasis and an MRI brain which diagnosed distant metastasis in the right frontal lobe. We saw Mr. DB in our clinic in February, and this time we made a diagnosis of paraneoplastic subcutaneous lupus due to his underlying right lung adenocarcinoma. As you can see, his autoimmune serology is highly indicative with a very positive SSA row. Unfortunately, Mr. DB has had a rather arduous course. He was admitted under radiation oncology for grade 3 acute radiation dermatitis. This worsened, and in mid-April, we admitted him as well. We gave him some topical dressings. We started him on Plaquenil for his cutaneous lupus and also a course of prednisolone whilst the Plaquenil worked its magic. At this time, we also did a biopsy away from the radiation site to exclude other disorders such as paraneoplastic pemphigus. Fortunately, it came back consistent with cutaneous lupus. So these are some photos of the morphology of Mr. DB's skin. We usually say with subcutaneous lupus, there's hypermelanosis in the center with a pink to red periphery. This hypermelanosis is usually reversible, which you will see in the future slides. So Mr. DB post-discharge, we saw him in hospital in a home. We doubled his Plaquenil dose and we weaned his prednisolone as he was improving. We continued him on topical steroids as well. As you can see, his erythema on his chest is improving. He has some erosions in the epigastrium, and we did do a viral swab, which came back negative as well. We saw Mr. DB again in our clinic a week afterwards, and he continued to improve. So most recently, we saw him again, and we've weaned his steroids down even further. As you can see, most of the hypermelanosis is resolving, his erythema is improving as well, and the erosions have improved. Thank you very much.
Thanks. Are there any questions about this case? Okay, so I guess the situation when you're dealing with an unusual scenario, we operate on Gestalt, but I think it's worthwhile considering the processes that are actually going on here. I've been boring my department incessantly about cognitive processes in diagnosis, but I guess what we're looking for here is with the this concept of unknown unknowns. We've got patients that often will sit up in this corner of the quadrant, and our aim is to move them down to this corner as we move through our diagnostic process to try and make the unknown unknowns known to us as we move on. So let's just run through some of these diagnoses that I've tossed out previously and just sort of try and quantify the risk. These are some of the conditions that I've mentioned. If we look at Sjogren's syndrome, first of all, there is reasonably strong literature to show that although the overall cancer risk is slightly elevated, there's a significant elevation in cancer risk if you look at specific types of malignancy, and in particular, a non-Hodgkin's lymphoma has a significant risk associated with this. Interestingly, also thyroid carcinoma has a significant increase in risk as well. For the non-Hodgkin's lymphomas, they're usually mucosal associated lymphoma, but the large cell B-cell lymphoma has also been described as being probably the next most significant group, but not to forget myeloma as well. So these things need to be considered, I guess, when someone's seeing a patient with Sjogren's syndrome. And the question is, I guess one of the questions is when and where should you consider assessing these patients, and what's the nature of this relationship? I found this graph really very interesting. I think it does suggest that this is one of the relationships where it is the disease promoting over time the occurrence of a secondary malignancy, because with looking at these Kaplan-Meier regressions, you can see for solid tumours and hematologic tumours, the incidence increases progressively over time. With lupus, it's a lot more unclear. I did find one article which said lupus is well recognised as a paraneoplastic phenomenon associated with lung cancer. I thought it was a very bold statement. When you actually look at reviews, they go between sort of a relative risk of 1 through to maybe about 1.5 if you look at all cancers. But if we drill down into that a little bit more, we see that once again, the non-Hodgkin's lymphoma and hematologic malignancies in general rate quite high amongst the associated tumours. But it gets a little bit more complicated when you look down. I highlight this because I think it's something that is often overlooked when one considers that the majority of patients with lupus are female, and many of them are older. I can recall in my days when I was doing obstetrics terms and gynecology terms, there was often a tendency not to pursue gynecological examinations in postmenopausal women. So this is a really important thing to recall. Lung cancer does have an association, but it's not a hugely strong one. Thyroid cancer, a little bit more, but not hugely strong. Prostate cancer is in there as well, and kidney also, but it varies according to the studies that you read. Interestingly, this is a small study, but it shows that in patients with thyroid cancer in association with lupus, a significant number, actually 80% of the patients actually showed evidence in their screening of thyroid autoimmunity as a component of their autoimmune disease, in contrast to those who didn't have thyroid cancer. Also, interestingly and consistently, and to my mind quite mystifyingly, there are reduced risks for breast and endometrial cancer in lupus, which is a consistent finding. People have tried to break this time and time again, and it's not been as successful. In contrast to the patients with Sjogren's syndrome, although this is not a Kaplan-Meier curve, the risk of malignancy associated with lupus appears to be most in the earlier years of the disease and drops progressively. So by the time you've had the disease for more than 20 years, you're getting really almost down to background risk. This is once again overall cancer risk, not looking at those specifics. So that suggests that maybe the relationship between lupus and malignancy is a little bit different from that seen in Sjogren's syndrome. Dermatomyositis is another step again. So the overall cancer risk is around 5.5 relative risk. That's maximal in the first year following a diagnosis of dermatomyositis. In another study, you can see if you look at just that first year, the relative risk is really very significant, but then drops progressively so that over 5 years, the risk is really quite low. And this tells us that really when we're approaching diagnosis and management of a patient with dermatomyositis, our decision about malignancy screening is a completely different scenario than, for example, the patient with Sjogren's syndrome. There's been a lot more focus on drilling down into this and identifying patients of greater risk. And anti-TIF1 antibodies have been reported as having a strong association with malignancy. I thought I'd just chase a little rabbit down into a burrow for a few minutes. TIF1 is a ubiquitin ligase, and I've written here it both promotes and inhibits malignancy. It promotes malignancy in that it inhibits apoptosis. So if you have malignant converted cell, it inhibits apoptosis. So if you have malignant genetically damaged cells, which by rights should self-recognize and undergo apoptosis, it inhibits that. But it also will inhibit malignancy in terms of its control of transcription. Anti-TIF1 antibodies, as I've already said, have a very strong association with the hazard ratio in this particular study of about 3.4. Interestingly, once again, when people have looked at TIF1 gamma genetic alterations in the cancers of people with cancers associated with myositis, they found that a very significant number of them actually show mutations of TIF1, which suggests that that may actually be one of the things driving the autoimmunity in these cases. So then it becomes not entirely surprising that most of the cancers are diagnosed relatively early after the diagnosis of dermatomyositis because they're already there. You just haven't found them necessarily. So that brings into question, what is the nature of these relationships? You know, is the cancer throwing the switch and inducing the autoimmunity? Is the cancer driving the autoimmunity, or are they all passengers in some other process? And when you look at the tumour environment, you find a whole lot of really quite interesting and in many ways difficult to understand and conflicting phenomena. So within the tumour environment and people with advanced cancers, you will see evidence of immunogenic tolerance being developed. In the early stages of cancer, however, the opposite is true. And early stage cancer is associated by an inflammatory environment. In fact, some have argued that that may be the initiator in some instances of cancer occurring. And that inflammatory environment mimics very strongly the inflammatory environment seen in tissues where autoimmunity is occurring. So in fact, that the lion and the kitty you can see is perhaps not quite so clear-cut as one might have thought, that in the early stages of cancer development, there's a lot of cross similarity between the two. I think when we're discussing these sort of things and talking about how we have Gestalt picking up malignancies in people, one of the things we need to consider is the next step of the unknown knowns. Those are the things that we think we know. And I put this up because there's a conversation that's had repeatedly. And this is just a quote from one study. I put it here because it's, I think, quite an elegant quote, which says basically, bullous pemphigoid is not associated with malignancy, and yet we repeatedly see patients with bullous pemphigoid being screened for malignancy. So the next question is, questions are when and who to test. Let's consider the patients that we've presented today. So we have here a patient where the clinical scenario is typical of paraneoplastic pemphigus. The investigations support that diagnosis. The diagnosis is defined by a malignant association, which is well characterised. So in these circumstances, and the camera's in front of it there, what we do is a directed process of investigation looking for the associated cancers. So in that particular instance, the process that we took was a logical process because that's what we expect to see if we're going to find a malignancy in this patient. If we look at our other two patients, what we had was a clinical scenario which was unusual. These patients presented with an unusually florid subacute cutaneous lupus. It was of acute onset and it was relatively unresponsive to treatment. So in those circumstances, although the investigations supported that diagnosis and alternative diagnoses were excluded. So for example, you remember the second case we talked, there was some suggestion of it being a lichenoid drug reaction. Really, that was considered extremely unlikely in this scenario because this patient hadn't had any medication for over 10 years. So in that situation where you have a really strong support for the diagnosis you've made, what we did then in these patients essentially is to undergo a case file audit. And in the third case, we found this evidence of his chest X-ray where a casual emergency attendants had found something which had not been followed up. And that then became the focus for our looking for something going on. And in the second case, it was really the clinical scenario and a past history of malignancy that caused us to then start to search once again in a directed manner and staged manner. So doing investigations sequentially looking for evidence of a cancer. And in her, what I was looking for was metastatic disease rather than necessarily primary disease. But in this man here, we felt that we were probably going to be finding a primary cancer. So then the next question is, I've mentioned this directed testing. So what sort of direction should we set? Well, these, I think, are the ones that come out most strongly out of the cases we've been looking at today. That hematologic malignancy in the context of the autoimmune diseases we've talked about today certainly are the ones that come out far and away ahead. So we need to work out a way of assessing these people appropriately. Thyroid cancer should not be forgotten, and I think it is something that is frequently forgotten in these people. Lung cancer is relatively easy to do. Subdiaphragmatic I put in there because renal cancer is the thing that leaps up most commonly, but of course we have other malignancies such as pancreatic cancer, which are notoriously difficult to diagnose. And usually when one's imaging the kidneys, one can make an appropriate choice to image the rest of the abdomen. And not to forget gynecological cancers, which are not entirely discovered by imaging. So it's not just sufficient to do a pan scan. You also need to look because cervical carcinoma and vulval carcinoma won't necessarily be seen on imaging. The next thing is to consider population sensitive. So if, for example, you're dealing with a population such as the Asian population, you should consider nasopharyngeal carcinoma as part of your screening. Many, many studies have linked dermatomyositis, for example, to nasopharyngeal carcinoma. You should consider other, in smokers and so on, you might consider lung cancer moving ahead, but also an age and sex appropriate screening. But I've written update there because I think that's really critical. If someone's up to date with their screening and you have no reason to assume that there's been some really dramatic change in their health, it's probably not appropriate to go repeating all of that. And that is something that I see done quite frequently. Although I note that it can be difficult to get the results of those screening tests, which should probably be sought. Next question is, of course, we're treating these people, and there'll be other scenarios where screening is appropriate too. So pre-treatment screening is important. If you're going to immunosuppress someone, it is, I think, entirely reasonable to make sure they haven't got a cancer, particularly if you're dealing with someone such as our 87-year-old. And in that circumstance, the best answer really is age and sex appropriate screening and nothing more than that. And that's also when it comes to outcome monitoring, when you're treating people with alkylating agents or long-term immunosuppression. It's important to understand that this is an ongoing process, but also considering treatment-specific risks as a modifier of that. So, for example, in someone on cyclophosphamide, considering how you might screen them for bladder cancer. So, a busman's tour through a very complex issue. It's something that I've been mulling over for some time and was brought to my mind again with our two cases that we've had this year. Are there any questions? Yeah.
Just a comment. Thank you very much for excellent talk. Thank you very much for excellent talk. Try to link the autoimmunity and cancer.
Yeah.
This is a very good thing, but I must, I would like to say, not everyone who's a positive ANA has autoimmunity, because ANA could be positive in 15% of healthy. Many cancers are manifested by dermatological first, and the cancer might appear later on. When you have an autoimmune disease and you're treated with immunosuppressive, the long-term immunosuppressive will precipitate a cancer. Number 4 or 5, there are some diseases which are pre-malignant, like Sjogren's syndrome, celiac, which Sjogren's syndrome. So these diseases will turn malignant, whether they develop autoimmunity or not. So, dermatomyositis, yes, it is an autoimmune disease, but even if you have a seronegative dermatomyositis, it is associated with a cancer. Celiac disease can be associated with T-cell lymphoma if the celiac disease is not under control. Ataxic telangiectasia will be manifested by a cancer. Pulmonary malignancy can be manifested by dermatological manifestation initially. So, no, I'm just saying comments. There is no question. This is my point. Yeah. Thank you.
Okay, thanks. Yeah, the issue of Sjogren's syndrome is a very interesting one, isn't it? Because the ratio is quite high. What they have shown, in fact, is that there are risk identifiers within patients with Sjogren's syndrome. And I guess one of the things we always ask or should consider, I think, when we're applying a label, and it's one of the things I try to explain to my patients, when you're given a label of lupus or a label of Sjogren's syndrome or a label of rheumatoid arthritis, the label is largely there for our convenience. What we're talking about is a collection of phenomena which involve a perturbation of the immune system for a variety of reasons. So they have actually identified within Sjogren's syndrome a number of risk factors which are very clearly linked to a progression to malignancy. And I think what's shown in that Kaplan-Meier curve there is that in these patients, it's probably the ongoing inflammatory reaction. Because remember, I said in malignancy, there is there's an initiation of malignancy can be associated with an inflammatory process. That's probably what happens in celiac disease too, the unchecked celiac disease, because you have people well controlled on a gluten-free diet for a long period of time. That T-cell lymphoma risk shrinks to negligibility. So it's probably that ongoing inflammatory process triggering. So yes, that's one of those circumstances where autoimmunity can set up a process down the track. And that's one of the things that you really need to be thinking of when I did that sort of that follow-up thing is how you should do it. So patients with Sjogren's syndrome, I suggest, should probably be considered periodically for some sort of screening. I mean, screening for hematologic malignancy. Is there a hematologist here before I verbal myself and get myself into serious trouble?
I can't see one.
It's excellent. Well, I can speak with freedom then. It can probably be screened for relatively easily with relatively simple non-invasive tests that don't involve a heck of a lot of radiation. That's one of the things that you could build in without breaking the bank. I guess one of the questions is, with some of these other conditions, is how often you should do it. And I can recall at an American Association of Dermatologists meeting, there are some amazing medical dermatologists in the US, mainly concentrated around Boston, really scarily bright people. And what they've said actually, in fact, is with dermatomyositis, they stopped doing their CT scans 3 years post-diagnosis because the risk of all of that radiation far outweighs any likelihood that you're going to pick up a cancer unless the person develops symptoms. So I think they're two quite different things. So I think probably the autoimmunity in dermatomyositis has been triggered by the cancer, just haven't found it yet. But in Sjogren's syndrome, it's probably the autoimmunity bringing the cancer along at a later date.
So Andrew, I was just for clarification as well, I guess because there's such a strong association with dermatomyositis, you would presumably do the screening initially. But if there was somebody who presents with cutaneous lupus, even just moderately severe disease, and there's no other red flags on the history or exam or anything, would you then just go ahead and treat them, assuming all the usual screening and things is up to date, and only then do extra screening if it wasn't following the usual disease course? Is that sort of what that?
Yeah, exactly so, yeah. And that was what moved us with both of these patients, is it was an unusual clinical scenario. Subacute cutaneous lupus doesn't usually present in that manner. And discoid lupus usually doesn't. So in those circumstances, you would have a fairly high threshold beyond the normal age-appropriate and sex-appropriate screening. Yeah.
Can you see that? When does the duration, the threshold for cancer screening in lupus fall back to the general population level?
Yeah. Okay. So the only study that I could find that really broke things down is that one that I cribbed the graph out of, which showed that it's maximal in the first 5 years and then drops away progressively. But 20 years out, it drops back to background. Mind you, of course, those patients are 20 years older and they're going to have the associated malignancy risks that's associated with being 20 years older, which is why the importance of continuing the background age and sex appropriate screening is there. Yeah.
And there's another question from Jeff Peters.
Yeah, many patients with autoimmune conditions have increased risk due to chronic immunosuppression. Did any studies count for this? Yeah, and it was actually really difficult when I was reading through the literature preparing this talk. Most of the talks talking about cancer risk are observational studies that are retrospective, case controls. Some of the very thorough ones used 8 controls for every case. So I think that'd be weighted enough, but they often tended to be centre focused. A large number of the ones associated with Sjogren's syndrome came from China, which means, of course, you're dealing with a different ethnic population as well. So it became very difficult to derive data from it, and it took a lot of searching to find ones that plotted the interval between diagnosis and cancer onset. But the ones that I did find, which were limited in number, did show that in lupus, it tended to be a bit more front-loaded. In Sjogren's syndrome, it tended to be a progressive risk. And of course, in dermatomyositis, it's very much a front-loaded risk. Yeah.
So there are some diseases which are pre-malignant.
Yep.
Like Hashimoto and Sjogren and dermatomyositis.
Yep.
Yeah, so it is by definition pre-malignant, and usually we do surveillance for this patient. If I have a patient who is myasthenia and is old, I will do MRI to exclude a thyroid tube. So there are some diseases are pre-malignant.
Well, I'm not know whether the pre-malignant is the term, but certainly very high association.
Yeah.
And for those ones, one needs to, once again, you've got to look at the risk and consider the patient in front of you. And of course, one of the other things is, which I didn't get to here, is that concept of the Pandora's box that you keep closed. So in a 93-year-old presenting with a condition that might suggest a malignant association, you need to have a very careful and informed discussion with that patient as to whether you're going to open that Pandora's box at all, or simply treat them symptomatically.
Physician. More of a comment rather than a question. So in various diseases, we have a lot of viruses and bacteria that are oncogenic.
Yeah.
I think the key problem is the oncogenesis is unclear here. Things like EBV hormone, which are really causing some hormones and all that. So I think what is not clearly understood here, what is driving the cancer pathogenesis?
That's a very good point. When I was reflecting on this stuff and I saw that vulval and vaginal and cervical carcinoma incidence there, I'm mindful of the fact that we're probably talking about a generation who haven't had HPV vaccination. So that may change over time. Yeah, and yeah, I mean, I'm one of those people who feels we really should have an EBV vaccine because it's a very nasty virus that comes back and bites people a lot through time. Yeah.
All right, well, I think we need to draw it to a close there. So please all join me in thanking Andrew and the dermatology department for contact with. I'm really great cases. Thank you.